Thanks very much, Sharon, and welcome to you all here in the lecture theatre here on a very lovely sunny day in Galway. And welcome to everybody who's joining us online as well. Hope it's nice where you are. You're very welcome to this session on reimagining home care for older people. This session is part of the HOMEDEM Doctoral Network event. This is an EU-funded network of Marie Curie doctoral candidates, and they're all working to enhance the quality of life of people with dementia in different ways. As Sharon said, I'm first going to introduce Caroline, then we have Brendan Walsh, and finally Helen, Rochford-Brennan, and time for questions afterwards. So I'm delighted to introduce Caroline McGregor. Caroline is the Director of the Institute for Life Course and Society, and she's going to give us a brief introduction now. Thanks.
Thanks very much. Fáilte go gáillimh, fáilte thug Institute Cuirsaí Síl, agus fáilte thug an inad seanolach síalta na hÉireann. Welcome everybody. So for anyone who understands our beautiful Gaelic language, I'm afraid I'm not a great Gaelgóir, but you're very welcome agus fáilte votes to everybody. Welcome especially to Galway, to the Institute for Life Course and Society, and to the Irish Centre for Social Gerontology. I'm delighted to have the opportunity just to say a few words. So thanks, colleagues, for inviting me to speak just at this wonderful HOMEDEM doctoral network. A fantastic network doing such important work in terms of supporting autonomous living and researching across a range of dimensions in relation to a focus on persons living with dementia and their carers and their families. And I want to say a very special welcome to the researchers from the network. We have colleagues who've travelled, so you're all very, very welcome to Galway. I'm sure my colleagues have already welcomed you warmly, but I would like to, on behalf of the University and the Institute, say that I hope your trip to Galway is going very well so far. And thank you very much for being part of this really, really impressive network of work. And just sort of we have, I hope I don't leave anybody out here, but a special welcome to our colleagues from KU Leuven and from the Lucas School of Arts in Belgium, to our colleagues from the Politecnico in Milano in Italy, from our colleagues in the University of Aveiro in Portugal, our colleagues from Eindhoven University of Technology, and our colleagues from Manchester University in Netherlands. A very special welcome to your project coordinator, Niels Hendricks, and to your project manager, Britt Pellens. Also want to say these events, don't they look so wonderful and well organised, and as if nothing could or would go wrong? But of course, you all know from your experience that that takes a lot of organising. So just to kind of congratulate and thank the local organising committee, Sharon and Eamon and Christine and Vamsi, for all of the hard work that you've obviously done. And I'm sure other colleagues in the centre who played such an important role in making this happen. And thanks also just to you doctoral candidates for being here. And a very special thanks for those. This is your open public event, and it's wonderful that you provide this in terms of your commitment to broadening our knowledge and giving access to your wonderful work to the wider community. So a big welcome to everybody who's here and to those of you who are online. And I'm just going to say just a few words, really, I suppose, just about the significance of this event. And then I'm also going to apologise to you that I'd love to stay and listen to the real highlight of the afternoon, your speakers. But unfortunately, I can't do that, but to wish you all very, very well for this work. And I suppose thinking about PhD, this is particularly a doctoral network. And just a PhD journey is a very special and unique one, as all of those you engage with will know. And you're becoming an expert, you're becoming an influencer, and you're becoming somebody who's having an impact in terms of knowledge as you do study that level of PhD. And then when you do a PhD in a subject, such as this important social and personal issue, it's even more significant and impactful in terms of your focus on promoting rights, care, support, protection, all directed, as I understand it, towards promoting autonomy within these complex, systemic and critical perspectives. So it's really, really, really important work. And it's fantastic that this work is happening within our Institute for Life Course and Society. Our goal is enabling equity across the life course And this kind of work makes such a substantial contribution in terms of thinking about many dimensions of life course that cross with your work, like that kind of looking at intergenerational relations. I think when you're looking at issues like dementia and looking at that kind of wider context, just the whole significance of life events, our past, our present, our future, that whole complexity in terms of health and well-being, and just that commitment that you have to promoting the rights of citizenship, the rights to autonomy, and the many ways that we can look at how those are prevented from being achieved and how we can work towards achieving it. So it's really a huge benefit and of huge value to us to have your network here, and well done to everybody who's brought you here to Galway, but also to your work, and we will be reading it. We read it already, and we'll continue to look to your work to continue to learn. And there's probably, everybody in this room is probably more expert than I am on the subject matter itself. I mean, I do have some experience. I have the pleasure of being in this institute, so it means I can learn directly from my fantastic colleagues, and I often look up the work and follow the work for my own learning as much as anything else, and also thinking about it from a sort of a critical perspective. And I suppose just to kind of congratulate you and to wish you all the best in terms of the complexity you're bringing to the theme and looking at the many, many dimensions of the work. And I suppose what I know, what I do know, and I think we all know, is there's some aspects about these issues you're looking at that probably are beyond our control, that we can't change, that we can't yet find a way to stop happening. Yeah. But there's so much in our control in terms of how we protect, sustain, maintain, and honour people's rights to autonomy and to continue to live a good quality of life. And so I thank you. I thank you for your work, because you're not just contributing to knowledge, you're contributing to knowledge that informs policy, knowledge that informs practice, and directly knowledge that can inform direct lived experience, and learning from those who have direct lived experience, triangulating that with those of you working, doing policy and experience. So just to thank you and to wish you all the best for your event and for your work. And it's been a pleasure to meet you even briefly, and thank you very much. Thank
you very much, Caroline, for that warm welcome. And we have a full afternoon ahead of us. So the first session, I'm delighted to welcome Dr. Brendan Walsh. Brendan is a Senior Research Officer in the Economic and Social Research Institute in Dublin. He's a health economist by background, with a particular focus on healthcare costs, access to healthcare, and health inequalities. And I know he's been working on and investigating home care in Ireland for older people for several years now. So he's very well placed, I think, to give us his insights on reimagining home care for older people. Thanks, Brendan. Did you know how to get it into full screen mode from SharePoint?
the bottom left here.
Yeah, that's okay for me. Everybody can see this okay? Yeah, perfect. So great. So thank you very much. And a special thanks to Sharon, Vamsi, Eamon, and Christine for inviting me to speak here today. I have to say, every time I come to Galway and to the ILAS, I'm always coming to something that's always very interesting to me in the work that I'm doing. I'm not always coming to weather which is quite as nice as this, so that's an extra bonus for everybody. But I also wanted to say that, the team here in ILAS more generally, they're providing a platform for a lot of dialogue in the areas of older persons care across the life course, which I think we don't offer enough in this country and probably internationally as well. So I think they should be commended for that, and also commended for putting this event together. I also have a little bit of envy in terms of, listening to the stories around the doctoral program that you all, or many of you here, are part of. It sounds fantastic. I didn't have that when I was a PhD student here in Galway. We had fantastic colleagues, but the international breadth and collaboration that you have here is fantastic. And like, the research community is very, very small. Even though you might look at broad aspects of different topics, you'll end up working with each other for years to come. And the collaborations you're putting together now are going to lead to, I suppose, collaborations in terms of research in the future, but also in terms of bouncing ideas off each other, and also kind of collegiality as well in the years to come. So today I'm going to speak about home care. It's a topic that I've done quite a bit of research in recent years, as Fiona has discussed. And just to kind of give people a broad overview of what the system looks like in Ireland, and hopefully where it's going in the coming years as well. I want to also kind of leave some space for Helen, who will be providing a discussion after this event, after my presentation, and also to the wider discussion after my talk, and also touch on a couple of themes and topics I think which will be covered across the presentations over the next few days as well. So I split my presentation in two. So firstly, it's about the here and now, how we've got here, and what the kind of system looks like, and how that might differ from the home care or home support systems that exist in other countries. I'm going to speak a little bit about demographics. So the demographics are going to become increasingly important when it comes to developing home care and care for older people systems more generally. And in the second half of my presentation, then I'm going to focus a little bit more on the future. And the idea of moving from care, moving to support in terms of how we develop the system, and give some kind of practical and maybe aspirational points on how I think we could improve the system as we move forward. So there's a lot of different kind of quotes out there in terms of how important this is, but this quote by Rosalind Carter, I always think made most sense to me. Basically, we're all going to be affected by home care, whether that's formal home care or informal home care, family care, whether we're receiving it, whether we will receive it, or whether we will be providing it. So when we talk about this area, it's not for those particular groups. We often try to look at a specific groups of people, like people with older people or people with dementia, but it essentially is going to affect most of the population at some point in their lives. So just kind of give you a kind of a bit of a background to where we are now in terms of the home support system in Ireland and how we got here. So kind of a little route. So from a policy perspective, the state has effectively been involved formally in home support or home care going back to the 1970 Health Act. So for kind of international colleagues, the 1970 Health Act is arguably the most important health act we've ever legislated for in this country. It's famous for two things. It developed regional health boards. We're not going to discuss that today because I think there will be a lot of discussion if we were to do that. But it also established the General Medical Service Scheme, or the medical card scheme. So this is kind of the first time the state had actually provided a form of public health insurance to the country at large, especially for those parts of the population which may find it difficult to access care or to pay for care. But it also established the home health scheme. People kind of don't think about this too much, but the state has been heavily involved in home care and home health ever since then. And it was the first time that local authorities were provided with the statutory right to start hiring carers, to hiring home helps, to start allowing for this care to be provided within people's homes. And we've had some form of this kind of home help scheme up until this present moment. It merged with the home care package scheme in about 2018. The home care package scheme was something slightly different. So it was established in 2006, and it was mainly there to allow people with certain kind of conditions or frailties to move home, to be discharged from hospital. It was to some extent a pull people home, but to a large extent it was to deal with kind of delayed discharges within hospital, kind of a pull factor as well. And within 2018, then both of these different schemes merged together, and we now have the kind of the HSE home support scheme, which is the major scheme provided by the state in terms of home care here. And from the very outset, I've kind of talked about the autonomy provided to local authorities. So compared to any other part of the system, home care has probably been devolved to the local level more than any other part of the health or the social care system, whether that's the acute system or the community care system. And to a large degree, you have little pockets of the country with almost their own unique models of care. So for example, a few years ago, in some regions, if you were to access a home care package, you first had to be a recipient of home health. In other regions, you did. So we have devolved home care back from the 1970 Health Act, and we have these kind of little pockets or little models of care which have developed across the country. And I'm going to touch on that a little bit more later. In 2014, then you also had the intensive home care package established, and Fiona and Sharon and others have done quite a lot of work looking at this in previous research with a clear focus on dementia. So Chuck Feeney, a philanthropist, was able to provide quite a bit of money, and the intensive home care package was formed to try and invest in kind of more bespoke packages for certain older people or people with dementia in particular. Now, unfortunately, if you actually look at the numbers, the number of people receiving care through the intensive home care package has fallen away quite a bit in recent years. So a lot of good intentions, which is something we see quite a lot in healthcare here, but a lot of what was promised or what should have happened actually didn't happen in the long term either. And I hope something doesn't similar happen when it comes to the statutory home support scheme. So there's been a lot of discussion about developing a statutory home support scheme in Ireland for a number of years now, which would place home support on the same statutory funding as residential care. So I'm going to touch on that in a little bit more detail over my next few slides. But this kind of gives you an idea of the kind of policy landscape within Ireland when it comes to home care and how we've developed home care within this country up until this present day. And I think in Ireland, compared to other countries, we have a very definitive definition of what home care or home support is. So in the past, the HSE have discussed that it's personal care and essential domestic care to support older people to remain at home for as long as possible and to assist informal carers. And that latter point, to assist informal carers, is very important here. More recent language by the HSE is quite explicit. It says the home care scheme does not intend to, nor would it be possible within the limit of the funding available, to replace informal care arrangements, but rather the intent is to support valuable informal care arrangements in Ireland. So you can see this compares quite differently to what exists in other countries. Especially in other Northern European countries, there's much greater focus put on the individual themselves. There's much greater focus put on autonomy, on things like independence, on integrating home care or home support with other health and social care services, integration with health, home adaptation, assisted technology, social care services, such as transportation services. We might be moving in this direction. From a policy perspective, we're still talking about kind of basic levels of personal care, essential domestic care, as opposed to kind of individual level packages and integration with other health and social care services. And this means that culturally and administratively, the care system in Ireland is very much built on the family care. So there's quite a few statistics out there in terms of the importance of family care. And Family Carers Ireland put together a scorecard each year, giving some of the kind of high-level results, which is included on the right-hand side of the slide here. But about 1 in 7 adults now provide some type of family or informal care, whether that's to a spouse, to a loved one, to a neighbour, to some other person within their community. On an average week, about 9 million hours of this unpaid care is provided. In an average year, the state provides just over 20 million hours. So if you were to aggregate that up to the national or to the annual level, for every 1 hour the state provides informal home support, family carers are providing 50 hours. And I think that kind of shows you the scope of family care being the bedrock of the care system here. There's a lot of discussion, as I showed in the previous slide, about supporting the family care, the informal care, integration care with them. But I think from anybody who's anecdotal experience, that doesn't happen quite a lot. And there has, what I kind of termed here for the presentation today, a carer care cycle has emerged. So the probability of somebody requiring care in the future is now much greater for those who provided care in the past. And there is quite a lot of evidence coming out of the US, coming out from Europe and China in particular, showing that for carers, especially for carers for older people, their functional health deteriorates at a much greater rate for people who don't provide care. Their mental health deteriorates at a much greater rate compared to people who don't provide care. And ultimately, there's this care cycle, which is once it gets started, it's quite hard to stop. I think in the last 8 to 10 years, there has been somewhat of a political and maybe a cultural and system shift as well. There's much more emphasis on home support by policymakers, not necessarily in terms of autonomy or dignity, in a lot of these other terms I'll talk to in a little bit, and other people in later presentations will talk to, but at least as a substitute to the kind of institutional or residential default, which has often been part of the care system in Ireland for many years. There's a greater understanding of the preference for home support to be emphasised in enabling older people to live independent lives at home. And I think a key part of this political shift came from the Sláinte Care report, which was published in 2017. For those who are not aware of Sláinte Care, we don't have a universal healthcare system here in Ireland like you might have the NHS in England. So Sláinte Care was a cross-political party report to try and provide some recommendations of how we might achieve a universal healthcare system in Ireland. And it very much put emphasis on a shift left. So moving as much care as possible from complex settings like hospitals, like residential care settings, into the home and into the community as much as possible. And I think while a lot of the aspirations of Sláinte Care certainly didn't come to pass, I think it did shape some of the political thought and approaches in terms of how home support and this shift left should be a key part of how the healthcare system is developed in the future. We all know that the COVID-19 pandemic shone a bright light on the care community and the care system more generally, but especially for residential care. And there was a COVID-19 nursing homes expert panel put together with a number of recommendations of how kind of the care for older people could be improved in the future, and especially within residential care facilities. And a number of these recommendations were about moving as much care as possible from residential facilities back into the home, where the home first becomes the default. And the last 3 programmes for government now have also explicitly included reference to establishing the statutory home support scheme. We're not there yet, but I think there has been a somewhat of a shift politically towards emphasising the importance of home care in more recent years. We're investing a lot more in home support as a state as well. And this has especially occurred during Minister Mary Butler's time as Minister for Older People and Mental Health. So in 2019, the HSE, which is essentially the coordinator and the commissioner of all public health care in Ireland, spent about 436 million on home support for older people. In the span of about 5 years, this increased to over 750 million. And this year, the budget looks like it'll be closer to 800 million. So we're talking a very, very large increase in investment. In the past, the home support was receiving maybe 30% of the support of the nursing home support scheme, which is the key state funder for long stay residential care within this country. We're not at parity yet, but it's up more towards 80% in terms of current budget investment in home support. But as anybody who has involvement in the system will know, supply is not kept up with demand. So we have increased the number of public home support hours provided to the older population from 17.5 million hours in 2019 to just over 23 million hours in 2024. But the green line at the bottom here shows you the number of recipients, and it's essentially plateaued. And even there's been a small reduction in the most recent years. Some of this is because we might necessarily be increasing the number of people receiving home support, but those in receipt of care are on average getting slightly longer or more intensive home care packages in terms of hours provided. But another explanation of why you're seeing quite a sharp increase in expenditure, but not the same level of increase when it comes to supply, is that a lot of the increase in expenditure was essentially soaked up by a new agreement between private and voluntary home care providers in the state. So in a few slides' time, I'll show you that the vast majority of home care in Ireland is provided by the private sector. And in these intervening years, the amount of money paid by the HSE to these private enterprises to provide care has increased significantly. That has taken up a lot of the expenditure increases, which you're seeing here, which is why you're not seeing the same increase in supply rates as you are when it comes to expenditure. But there are a couple of other reasons why we're not seeing this large increase in individuals receiving home support. The first is a shortage of carers. So this graph here shows the number of people on a waiting list for a public home support scheme in Ireland going back to 2018 by month. So in most recent years, somewhere between 5,500 to up to 7,500 are on a waiting list for home support. So we're talking about quite large numbers when you think that just over 50,000 people receive home support in any given month. In the past, the reason for these waiting lists was basically there wasn't enough funding to provide the care. We've provided an awful lot more funding now into the system. Now it's the availability of carers, which is the predominant reason why individuals are on a waiting list for care. But half of these waiters are waiting for any type of home support, while the other half are essentially waiting for additional hours to be provided within their packages. And one of the reasons for this is, home care is in a recruitment and retention crisis, not just here in Ireland, but also internationally. Often you hear people talk, we're heading to a crisis. We've been in a crisis, I would argue now, for a few years. Caring as a profession is very difficult, and it's very often underappreciated as well. And the underappreciation can be seen in terms of low pay, difficult working conditions, and also the lack of career development. At the ESRI a few years ago, we did a piece of research where we compared the caring workforce to other professions in the economy. And for individuals who worked in the caring sector, they were more likely to live in the most socially deprived areas than any other part of the compared to any other profession. They actually had a greater probability of living in a socially deprived area than the unemployed population. And more recent work has shown that while there has been some improvements to pay, where there's now a living wage provided to many carers, the caring profession is now essentially a minimum wage career. And it's going to be very difficult unless the pay and the conditions for these workers improves to get enough individuals within the system to meet the demand. And then from the recipient's point of view, obviously waitiness is one negative outcome. For waiting for care in the first place is quite a poor outcome. But we know from the academic literature, continuity of care with healthcare workers matters a lot. So for an individual who is in receiving care, whether that's from a GP, from a consultant, from a therapist, receiving care from the same therapist, from the same GP over a number of years improves outcomes. And it's the same when it comes to care. But we have a situation now where there's a huge amount of carer churn. Individuals who are receiving care might see multiple carers in a given month or in a given year. And just from the individual's point of view, this can be quite stressful. It can be stressful from the family carer's point of view too, because you're accepting somebody new into your home continually, and it puts pressure on the care recipients and their families. It means that the individuals themselves is constantly required to kind of delve into their healthcare needs, their preference, and so forth, and relay this to new carers on a continuous basis. And we know there's also a skills issues. The skills do not match needs. There was research published during the COVID-19 pandemic from UCD that found that about 50% of carers had no training in dementia care, for instance. So we have a kind of a key issue when it comes to workforce here, both in terms of the availability of the workforce, but also in terms of the paying conditions and the type of skills that these carers are providing to individuals in need of support. I mentioned at the beginning as well that home care or home support is quite unique in an Irish healthcare system, where we have devolved quite a lot of autonomy to local decision makers. And you have almost these little models of care which is developed differently across different parts of the country. And what this graph shows you here is the proportion of home support hours per capita provided in each of these new HSE health regions. So we have 6 new HSE administrative health regions within Ireland. And you can see there's quite a lot of variation across each of these regions. We're doing work for the Department of Health at the moment where we are undertaking a capacity review, where we're projecting the amount of healthcare capacity and social care capacity which might be needed in the system moving forward. We're doing this at a national level, but we're also doing this at a regional level. And I don't think there's any other part of the system where we're seeing the same amount of regional variation when it comes to the supply of a particular healthcare service as we are with home support. And kind of just to put the level of variation into context, Dublin North East and Dublin South East, they're linked. They're only split by the River Liffey. But in Dublin North East, there are 38% more hours per capita provided in a given year compared to Dublin South East. Now, there might be a number of reasons for this. People living in Dublin South East might be purchasing private home support, for instance. There might be slightly different levels of other support services. But this level of variation within a public health system is quite unique, not just internationally, but also within the Irish healthcare system. And I also mentioned that a large proportion of home support in Ireland is now provided by the private sector. We very much kind of privatise provision for older people services, not just home support, going back a number of years now. So these figures here are from 2023. So 61% of all publicly funded home support is now provided by voluntary to private sector. But again, you can see there's huge variation across different parts of the country. In Dublin North East, on the left-hand side, are Dublin Midlands, Dublin South East, the kind of East Coast. Over half or the vast majority of public home support is now privately provided, while on the south or the west coast, we are talking about lower amounts. And I think this also kind of shows you the different types of care provision and models of care which have developed across different parts of the country when it comes to home support. And then finally, the lack of a statutory home support scheme is kind of another negative here. In 2009, there was another large piece of legislation brought forward called the Nursing Home Support Scheme Act. And it provided a statutory framework for the first time for individuals in need of residential care to receive it and the proper funding supports to be provided to them. We do not have the same statutory footing when it comes to home support. There's been a number of calls and research into the establishment of this statutory home support scheme made for decades now. So Eamon, who's not here today, and colleagues did work back in 1993, NESC in 2015, Launch Care called for it, the expert panel. Myself and colleagues at ESRI have also done work looking at the potential of developing a statutory home support scheme. And even though it's included in the latest programme for government, I think a lot of intentions and promises need to become actions in order for the statutory home support scheme to be developed. So I hope that's kind of giving you an idea of the context of home care in Ireland more generally, and how it differs a little bit from what you might see in or experience in your own countries when it comes to home care. But I also want to touch a little bit on demographics, because demographics are going to become very important in terms of the type of system that we develop here. So over the last 2 decades, the older population has doubled, whether that's measured as kind of 65 plus or 85 plus. We've essentially seen a doubling. And we've done work in the past showing that the biggest driver or determinant of demand for home support is driven by the population age structure, the increases in the population at older ages. And in the next 16 years, we're going to see a doubling again. It's going to increase. And this is from projections published by, again, colleagues at ESRI last year. The median home support user is about 84, 85 years of age, which means that about 50% of all home support recipients are over the age of 85. And you can see that compared to 2006, and moving all the way out to 2040, population aged over 65 is almost going to treble. So for that cohort in particular, who might have slightly greater levels of complex needs or dependency, we're going to see a large impact on the demand for home support. Now, when I'm an economist, as Fiona alluded to in the past, when we start talking about these changes, we often put them as very kind of negative things. Demographic crisis is something we hear quite a lot. And I think it's somewhat ageist, it's somewhat dehumanizing, because what essentially this means is that we're living longer, we've lower mortality. Ireland has gone from being essentially the basket case of Europe when it comes to mortality 30 years ago to having some of the best life expectancy and lowest mortality across all of Europe. And the vast majority, the main reason for this is improvements at older ages. So older people are living longer. We need to set up a system that allows us to cater for that. If you hear of a child being born, the first thing you think about is not, oh, we need more schools or we need more teachers. The planning is there for that. And I think there needs to also be a mindset shift in terms of how we relate to these demographic changes when it comes to the increase in older people. So society is changing, and the planning of the systems will also have to change to meet that change. And there's probably no area compared to home support where such kind of changes in terms of societal output needed. There are also other important demographic issues going on in the background. So for instance, we know that female labour force participation is increasing, which might affect the supply of informal care. We know that the size of families are getting smaller. Again, that might impact the number of people available to provide family care. Long-term relationships, we don't have as many long-term relationships as we did in the past. So there are these other demographic drivers, not just population, which might have an impact on the demand for more professional or state-provided home support services. But another key demographic trend, which is getting a little bit more traction now in recent years, not just in Ireland, but in Europe, is our housing situation. There's going to be a lot more people in the future reaching retirement age, reaching older age, and to do not own their house. And how we deal with that is going to have knock-on repercussions for how we deal with the home support sector as well. So this is a piece of work which was published 3 years ago now, which shows the percentage of individuals at each age group at different points in time who are homeowners. So on the right-hand side here, if you look at the 65 plus, which is kind of the blue navy line, you can see that going all the way back to, say, about 1999. If you're reaching the age of 65 in 1999, 2004, 2009, 2015, about 9 out of every 10 individuals are homeowners when they enter retirement. Not only that, they don't have any mortgages, they don't have any rent and so forth. If you look at the cohort age 45 to 54, who will be turning 65 in the next 10 years or so, that has dropped down to about 78%. So we're going to have a situation in the next few years where about a quarter, between a fifth and a quarter of individuals who are moving into the retirement age, into the older age where home support, for instance, or other care service might be required, will not be homeowners. By definition, home care needs a home. So there's going to be a lot of debates going on behind the scenes in terms of rights to home ownership, changes in terms of rental agreements, possession, and so forth, which have knock-on implications for home support policies as well. And if you bring this forward into the future, if you look at maybe a lot more people in the younger cohorts here as well, home ownership rates have dramatically changed in younger populations as well. So we're moving into a society where there's going to be much less people living in homes their own, and that's going to have knock-on implications for the policies that we implement for providing care at home as well. Don't have any solutions for this, but I think it's something that mightn't be appreciated as much when we start thinking about how the system might evolve to meet the future needs of the population here. So you often, if you ever watch some of these programs like Reeling in the Years, which looks at the past and what happened in previous years, it often feels like at certain moments in time, you know, major changes in history happen. And often people say this is a key moment as we move into toward the future. But I do genuinely think these years here are very important in terms of the direction of travel when it comes to designing a home support scheme for older people. We're at an inflection point, and we need to make sure this inflection point doesn't become an impasse. I think we have political movement to expand home support, using information provided by Sláinte Care. You now have a new Commission of Care for Older People, which is looking into developing a better model of care for older people in Ireland more generally. And as I've shown you, the governments themselves are now talking about establishing a statutory home support scheme. And they've started early steps towards this, including regulation of the system, which hasn't been included before. But promises need to lead to continued actions before we see these developments happen. So in the next few slides, I'm going to try and discuss, I suppose, 5 key issues that I think are important to develop in order for us to establish an efficient and effective home support system in Ireland. First of all, I think we need to move from thinking about care to thinking about support. So caring for people's clinical and non-clinical needs will always remain important, including when we talk about home support. But we need to be designing a system that moves from home care to supporting the individual to live the best lives they've required. Each one of us in this room here have different preferences. We know what we want. We don't have this kind of homogenous outlook on what our best lives would be. I think we have to take the same type of approach when it comes to home support. And this is kind of the direction of travel quote that I put together for this, using some information from the WHO and the UN and others. I think home support is to become part of an integrated, person-centered continuum that blends clinical management of chronic conditions, rehabilitation, potentially palliative care, health promotion and prevention, together with assistive care and social support services, so that people can live a life consistent with their rights, freedoms, and dignity. Now, some people in the room might have come across Professor Ian Phillip in the past, who is kind of a researcher in the area of older people's care. He was the clinical director for older people services in the NHS for about 10 years in the 2000s. And he's done quite a lot of work thinking about the approaches we have to care for older people more generally. And we talk about dignity quite a lot. Right? So dignity refers to an individual maintaining self-respect and being valued by others. So valuing a certain group by providing them with services that they need is important. But autonomy refers to individual control of decision-making and other activities. Putting the decisions in the hands of the individuals who need to make it also becomes important. So I think without autonomy, the dignity element, which we discuss quite a lot, becomes a little bit moot when we think about policy. So I've identified 5 key technical changes. I'm an economist, so I always go back to kind of the technical element, the practical element, that I think need to be implemented before we even think about developing an efficient and effective system. But I've also thought about the mind shift changes, whether that be the state, society, or individuals themselves need to have to achieve these. So for integration of care, how about integration in terms of a social model of care, not just a medicalized model of care? Systematic assessment, we need to know what people want, we need to know what people need, so that we tailor supports for their needs, but also their preferences. We need information. It's very difficult to create new policy without data and information. But this information isn't just there for policymakers or researchers like myself. It's there to empower the individual recipients and to provide greater autonomy. I do think we need a statutory home support scheme to place it on the same footing as residential care, so that we have this home and community first default mindset when it comes to providing care for older people. And as I showed you in a few slides, demographics are very, very important. Not in a scaremongering way, but just in a reality check. We need to future-proof what we're doing in terms of the system here. So I put together a slide here using information from TILDA, which is the Irish Longitudinal Study on Aging. And typical, I know the word typical isn't perfect. I couldn't think of any better term for this presentation. But a median home support user is 84 years old. So if I was to look at an 84-year-old home support user in TILDA, nearly all of them go to the GP 5 times a year. About a fifth of them use inpatient care in a hospital, use physiotherapists, public health nurses. Some use day centre care. Some use convalescence or short stay care. Polypharmacy is quite big. About 60% of these individuals are on at least 5 medications. They have difficulties with activities of daily living, but also difficulties with instrumental activities of daily living. So the kind of basic tasks, but also the tasks they need to live the lives they want. About 42% have moderate to mild cognitive difficulties, which could include dementia. Maybe the most worrying of this is 20% have only 1 or no people that they're tied to. So their social connectedness is less than 2. 42% have fallen in the last 12 months. So in terms of the types of health and clinical care needs this person needs, it's quite broad. So in terms of integrating home support, I think it's going to be, in terms of this wider model of care, clinical model of care for older people, it's going to become very important. So integration, the services should wrap around the individual based on what they need. Embed. So we have developed these more localized, enhanced community care hubs, where we have integrated care programs for older people. We have public health nurses working with occupational therapists and social workers, etc. The home care coordinator could be included here. It's quite a very simple, practical solution that could help to integrate services. Assessment. We do not have a fully rolled out systematic assessment across the country. Many of you here might have come across InterEyes, kind of this internationally recognized statutory assessment tool used in Canada, New Zealand, Denmark, basically all of the countries, the kind of more developed countries when it comes to older persons care for over a decade now. We're slowly rolling that out. We need to get that out quicker to individuals. And also funding. Again, from an economist's point of view, funding is always going to matter when it comes to decisions. But money should follow the person, not necessarily follow the service. I think we're moving in this direction a little bit at the moment. So we are developing a population-based resource allocation mechanism in Ireland, which should allow more equitable allocation of services in different parts of the country. But step 2, 3, and 4, as we move towards person-centered care, is going to become increasingly important as well. But a typical home support user is not just a user of healthcare. They're a mother, they're a spouse, they're a friend, they're a neighbour. They could be a good neighbour, they could be a bad neighbour. They're a carer. They drive cars, they take buses. They're a worrier. They might go to mass on a Sunday. They're financial planners. There's these other things that are going on in their life. And I think we have an opportunity to tailor this integrated care system to focus more on these type of needs as opposed to their clinical needs. This means choice, tailored packages to meet people's needs and preferences, not just in terms of their healthcare needs, but in terms of what they want to do. Flexibility. A 30-minute visit at 9 o'clock on a Monday might suit a carer or a provider of care, but it may not suit the individual themselves. Home. Adaptions in the home are very important. We talk about this a lot in Ireland, but there's so much more we can do in terms of adapting the home to provide a safer and more comfortable environment for the individuals. Community, but in terms of reablement, getting back into the community, social prescribing, could be as simple as allowing for a local link bus route to allow 2 individuals to meet for a cup of coffee. And then family carers. We talk about family carers in terms of our description of home support here. The service needs to complement them, help them as well, not just something that's provided in non-integrated care, and what they want, what their preferences are. I took liberties a little bit in terms of this quote because I couldn't actually find a quote by a famous person that encapsulates the kind of frustration myself and Sharon and I'm sure Kieran and Fiona and others have when it comes to doing research here. Never mind about the care recipients themselves in terms of moving from what they need to what they receive. So the quote is, we don't always know if a home support recipient in Ireland is male or female or what age they are, let alone how the service can support them. So when I do research in this area, there's often data that I receive from administrative sources that I can't even tell if they're male or female. So it's quite basic issues we have here instead of us moving towards looking at some of the more aspirational stuff, even though I've talked about it in the previous few slides. Again, you might have seen a version of this cartoon many times. So you have a person who's lost his wallet in the park. The policeman asks, "Is this where you lost your wallet?" And he replies, "No, I lost my wallet in the park, but this is where the light is." It's very difficult to look anywhere else if light isn't shone there. And I've been thinking about, sorry, I know I might be going a little bit over time here, Fiona, am I? But I've thought about this slide a little bit over the last few days in terms of how resources are distributed across the healthcare system. I think it's probably not an anomaly that hospitals tend to soak up a huge amount of funding here. And I think one of the reasons that is they're very good health information systems. We know what's going on there. If you know what's going on and you're a stakeholder or a policymaker or a politician, it's quite easy to make decisions when you can measure it. When you can't measure it, it's very difficult to do that. So I think, as I mentioned in a few slides before, the full rollout of a single assessment tool, potentially Interact, is an imperative for the system here. Health information systems in Ireland are also quite poor, but we need to develop them, not just in home support, but in the wider healthcare system that capture the needs and the wider health and social care services that an individual requires. And then the third point, the health researchers like me, if nothing else, to have better centralized data collection so that we can actually do research that informs policy. And if we're going to measure effectiveness, we need to choose the right outcomes. What are the aims or the benchmarks? As I showed you previously, there's huge regional variation across country when it comes to home support. Why is that? Are we benchmarking supply across different parts of the country? Do we know what family carers want when it comes to home care packages? And what about the quality of life of the recipient himself, which is increasingly important? And for the recipient, the person who's receiving the care, information is also very important. And I think there's often a fear amongst people who might work in a system or the individuals themselves when it comes to information and data, that it becomes quite complex. And if you ever see a lot of the companies who are trying to sell information systems, they're trying to sell systems that are often designed like high-performance treadmills designed for competitive athletes. They're complex, they're intense, and they're overwhelming. When most of the time, what's actually needed when it comes to data and information infrastructure is a simple walking track, something that's accessible for individuals, that's straightforward, and that's tailored for steady progress. And as we move towards developing a better health information system and focus a little bit more on the second point here, it'll provide greater autonomy to the individuals who require and are using the care themselves. Because I think there is a possibility to use home support more effectively as well as an information service. You know, more broadly, health information systems need to inform and empower the individual. And often the most difficult part of accessing healthcare is navigating the system itself, having those signposts available for the individual or for the family care on where they can receive the care or what type of care might be available in the local community. When it comes to, say, social prescribing, is there women's sheds, is there men's sheds in your local area? Planning then. So previously I showed that the population into the future is going to increase by quite a lot at older ages. We published a piece of research a few years ago now where we projected the amount of expenditure that would be required between 2019 and 2035 for home support. And even taking a relatively conservative estimate here, we expect that spending on home support could reach, the demand for spending on home support could reach about 2 billion in the next 16 years or so. That equates to just about a doubling of the expenditure that will be required. A key reason for this is the population aging aspect, because that's the key driver of demand. But what we actually found is the biggest driver of the cost projection increases was the cost of providing the care itself. If we want to encourage people to get involved in the care sector, we simply have to pay them more. If we do that, that's going to cost more money. But the benefits in terms of, that could be cost reductions, but in terms of quality of life individuals, could be quite important by doing this. And the planning begins now. 2025, we're 6 years into this time horizon already. We'll be reaching 2035 quite soon. Planning for the future as quickly as possible is important. So this is my final slide. I think I'm on time, Fiona. So the four key takeaways from this, that's not just in terms of what I spoke, but I hope it sets up Helen's discussion after this and also maybe some of the questions that come our way. The home support system is at a very important point, and there's an opportunity here to determine whether it's an inflection point or we've just come to an impasse. Planning is needed to meet the large demographic changes that are happening, but we don't need to approach this in a very negative way. But a mindset shift is certainly needed towards person-centered care and preferences, aided by clear technical improvements. It's very difficult to move towards the person-centered care unless you have those technical aspects in place as well. And I think by doing this, a rights-based, outcomes-orientated, fully resourced home support model is achievable. But we kind of have to act now. The future starts today, and it's going to be kicking in quite soon. So thank you very much.
Thanks very much, Brendan, for that very comprehensive and wide-ranging and thought-provoking presentation there. I know I was sort of scribbling some questions and thoughts furiously, so I'm sure we'll have plenty of time afterwards for questions. I want to introduce our respondent, if you like, to Brendan, and I'm delighted to welcome Dr. Helen Rochford-Brennan. Helen is a global dementia ambassador. She's the former chairperson of the European Working Group for People with Dementia, and she's a board member of the Alzheimer's Society of Ireland and Alzheimer's Europe. And she also has an honorary degree from this university. In fact, both our speakers, I should have mentioned, Brendan is also a graduate of the university here. So delighted to welcome Helen.
Thank you. Thank you for giving me the opportunity to be with you today. And thanks to Eamon and Christine and the whole team, all of you, for getting me back here again. I love to come home. I want to thank Carmel for giving my support, who travels with me around the world trying to make changes. So my first contact with this college was through I'm a great believer in social justice and human rights. So I was diagnosed at the age of 57 with early onset Alzheimer's, and it took 5 years to get a proper diagnosis. And then there was nothing for me. There was no care, there was no support, there was none of these great things that Brendan was showing up there on slides. And so I just became enraged as somebody that believes in social justice and human rights. And can I say to all of you PhD students, no matter where you are, if you don't have social justice, you don't have human rights. So that's how I began working with Professor Eleanor Flynn here and doing some work on each year assisted decision making. So just tell you a little bit about myself. I live alone. I'm not going to give you any slides because I have short-term memory and I cannot remember. So you'll all bear with me that I cannot remember all that Brendan talked about. But I'm going to tell you what it's like to live alone with Alzheimer's every day. And I think it will feed well into what Brendan has talked about. So I was one of nine. I had 4 brothers and 4 sisters. I was married to Sean, who passed away during COVID. And I have one son, Martin, who lives in New York. And I have a dog, Lexi. And Lexi keeps me moving every day. And I think it's important that when we look at what gets us up every day and what keeps us going, but that's the important thing, that we have a sense of purpose. And for me, I'll just give you a little bit about my own international experience and the voices of my friends and those living with dementia about what it's like to live alone and how we can eliminate some of those statistics of going to the doctor every 5 minutes with a pain here or a pain there, that we can live alone and we can have a sense of purpose. I have 2 friends in Scotland. Some of you may have heard of Agnes Houston and Tommy Dunn. They live alone. They're absolutely powerful advocates for showing that our voice really matters and that we have really daily purpose. And in Australia, you know, many of my friends there, you know, they have community gardens, they have libraries, they have all kinds of things that they go to. And then there's creative contributions, of course, also in the Netherlands. But one of the things that's forgotten sometimes about when we talk about staying at home is security and safety, dementia-friendly technology. So for me, that is one of the key things for me to live alone, is to have technology. And technology entered my life when COVID came and our health service asked me, would I be interested in trying out Alexa to see if it would help do some research and see would it break down isolation in rural Ireland. And I hadn't heard of Alexa, and I certainly had no idea how to plug Alexa in, much less anything else. But it gave me a great sense of hope that today I cannot live without Alexa. I cannot live without the technologies that I need to, my day, every day is around technology. So Alexa can tell me when to get up. Alexa can tell me to take my medication. Alexa can give me all my instructions throughout the day. And then I can go on Google or I can go and chat and I can ask them, God, I'm meeting this fella tomorrow, Brendan Walsh, I haven't a notion what I'm going to say. How do I rephrase this line? And so someone is going to tell me how to rephrase the line, or Alexa is certainly going to tell me how to spell the word or what the spell. So I'm sitting at my table sometimes and I'm trying to do a speech and I'm trying to remember what the word and in another word, or I don't understand this word. And I'll just say, Alexa, what does this mean? You know, and that's how we live. If we want to live well, we want to make a contribution to society and still continue to be safe. You know, it's about having the systems. You know, I have a smartwatch. Okay, the smartwatch, I thought I'd never get used to. I hadn't a notion. My son insisted I had to have a smartwatch. So what do? You take it. But now my smartwatch helps me because I have an abnormal heart rhythm. And it says to me, Helen, I get a message that says your heart rate has dropped below 39 for the last 10 minutes. So you have to do something. I have a heart monitor that goes off in my hospital if something goes wrong. And I have cameras around my house because I live alone. You know, I have a Ring doorbell so I can immediately see who's at the door. You know, I have and they're all great. Can I say having all these monitors in my house are wonderful. And then in rural Ireland, guess what happens? The electricity goes off. And then how in the hell am I going to turn all these things back on? Well, I've got a magic person that comes to visit me twice a week, and every other week she comes 3 times. And her name is Erin. And Erin is my home support person. And she helps me to come in and turn all of these things on, because all of you turned on, you know. So those are the things that are important I want you to all to remember, for us to live a quality of life and to be able to get on with our lives every single day and to have that. And it gives me, having that gives me a great sense of not being afraid. And fear is a huge thing for people with dementia. Let me tell you, it's a very real thing. So I am not as fearful as I used to be about living alone and getting on with life. But, you know, we have to look at what makes us happy and what gives us a quality of life. How often do I see my GP? Well, if I saw my GP twice a year, I'd be doing well. And he'd definitely be doing well to see me. Because I get up every day and I open my patio door and I hear the birds sing. I have my morning sing, and the dog is there waiting patiently, giving me a growl that he needs to get out. So I don't have to have an alarm clock unless I'm away, because the dog needs to get out. So when I talk about a sense of purpose and I talk about wanting to belong in my community, that's who helps me to live well, to live a quality of life, and to live a life with hope. And I want all of you to go home and keep repeating that word hope, because I do not have any medication to help me to live this life. All I have is hope, hope for the future, hope that now with all these new medicines that I have spoken out for the last 13 years, that it has helped change the perception of what people with dementia are. You know, they think we should all look drab. One of the biggest problems that happened in our house when I was diagnosed was that my husband had a Parkinson's type shake. And you know what his greatest worry was? His greatest worry was that he wouldn't be able to put on my lipstick. It wasn't about how my diagnosis was going to progress. It was that I was still going to wear my lipstick. You know, that was the big thing that was important to it. And, you know, there's simple things, but they're things that really hope connects all of us. It connects all of us. And, you know, that lived experience and, you know, public awareness and providing that we can still be seen and heard and needed. And then it's great to have peer support as well. So I have peer support and friends in other countries. And then I want to say that there has to be moments of joy every day in my life. So when I walk the dog, I live in a small town north of here, a couple of hours away. And I'm never isolated, because if it's school time, every child on the road will want to pat the dog, and the dog will be absolutely delighted. So I have met somebody new. And this happened after COVID. You know, when I walked the dog, and there were all new families, and it's working from home now, and they were out with their dogs, and we didn't want to see too many small ones because they weren't like my Labrador. But there are moments of joy of meeting others and meeting every day. So my walk entails meeting lots of people, but I never have to worry about what's going on in the world, because somebody is always going to tell me, did you see the news? A certain person, guess what he said today? So I don't really want to hear about that certain person in the world, but you know, it's great. And it's just also about bringing together a whole system of approach. And we say about a layered system, and a layered system, you know, it's no one service. You know, there's, you know, we need to look at, as you said, Brendan, whether it's medical, technological, social, you know, they're all there for us. And people need those layers to help them to live as well as they can. And as I said about safety, you know, it's another thread, but it helps people living alone, you know, never to feel alone if you have the safety. And then we have to have relationships, you know, so it's about my relationships now are all over the world, you know, talking about dementia. If somebody told me when I was diagnosed that I'd be still speaking here 13 years later about what's needed, I would never have believed it. But because I've got hope right here in this building, from Professor O'Shea and Fiona and Maria and all of these people that work here, you know, that have helped me through the years. And that's given me, again, a sense of purpose and a sense of getting up and saying, you know, I do make a contribution and I do want to see change. And it's good to see people like Frances here. Frances, who's worked in the caring since I got to meet you first, Frances, and to be here and to learn and to understand. And we continue to listen and be present, you know, be present. I think that having that connection and having a joyful time of living with dementia, you know, going to a social club. Now we call them meeting places. The latest is a meeting place. So we don't want to talk about social clubs, and I'm not for a centre. Centres are for people. And many people enjoy going to a centre. Sorry, I don't enjoy going to a day centre. I enjoy going to a social club where I can have a laugh, and as they say in Ireland, crack, C-R-A-I-C. It is not cocaine, but it's a way of laughter and joy and happiness. And we have that, you know, we can sing, we can laugh, we can talk about what's going on in the world. And also we want to talk about green care. Has any of you heard about green care? Well, Carmel might tell us a bit about green care. Well, green care is about getting outdoors. We're great at going indoors in Ireland. God, it's too cold. I can't go out today. It's raining. You know, I have Alzheimer's. How could you expect to go out in the rain? Well, I'll tell you what, I went to Canada in November with Carmel, and I learned all about green care farms. Because if you have dementia in Canada, you put on your coat and your wellies and your boots. So I had to invest in a pair of boots in Canada and get out onto a farm and look at all the different animals and see the joy on the faces of people with dementia, not stuck at home, not stuck in a day centre. They're out and about. And honestly, it's just something that you can look at in the future. It's just such amazing. It was just so amazing to see. And where do we have our lovely lunch? Everything arrived, and we're in a hay shed, and we're sitting with having our lunch in a hay shed. And I could imagine asking people in Ireland to come and have lunch. It was fabulous. So, you know, if you want to have a glass of Prosecco, you could have had it too in the hay shed. You know, so you can have what you want. So it was really, really good. So again, I want to go back to, you know, about having a rights-based approach. And it must be rights-based for me. because, and for everybody, we shouldn't have to ask for it. We shouldn't have to be begging all these years later for a statutory right to live at home. You know why? You want me to go to a care home? Well, a couple of years ago, I had a stroke, and as I lived by myself, there was great consternation in the family as to what would happen to me. But I left strict instructions that I was going to take a case against the state if they did not provide me with the care to stay in my own home. And that's still on the cards, might I add. I keep threatening, you know, if we don't have the right supports, we're going to go and look for them. But I think that, you know, and we've made changes in our decision making here in this country under the UN Convention of the Rights of People with Disabilities, because we have now have the optional protocol, which gives me the right to actually be able to take a case, should I so wish. I wouldn't want to go down that road, but I would like to see that everybody has the right to stay in their own home with the appropriate supports, whether it's through whatever means. You know, I don't have a family that can support me. Sadly, I don't have a family that can support me. I have nieces and nephews that live nearby, but they're all have young kids and they have their own lives, you know. So I think you have to look at what we really need and what is appropriate, and why wouldn't be a statutory right to live in our own home. I'll tell you that by me living in my own home and by having the layers that I need, you know, it's really going to help me, you know, to stay well in my own home. And I just think we need to recognize and have all our policies and our experiences, you know, that we can put them all together and we can share our knowledge with the government, as we have been doing for many years, people with dementia and the carers network and whomever, service providers, and to try and influence the change that living at home is good for us. I go to things I do. I belong to a women's group. I recently joined a gym which is called Hello Good Life. It's a new initiative in Ireland. But, you know, I don't have to work too hard. I sit in 12 chairs and lie on 3 beds, and they all take every bit of action that my body needs. It's done all in one go. So, you know, it's important to remember that there are all kinds of things like that that keep us well and keep us safe and keep us young at heart. You know, keep us young. We want to have a lot more intergenerational. And I think for me, having that intergenerational is really, really important. So I broke it down into simply for Brendan, because I wouldn't remember it all. So I thought, well, if we talk about the things, you know, that we have to have a call to action. I mean, we really need to, you know, we need to recognize that home care is a human right, and we need to find flexible, personalized care. We're all different. We're all completely different. So we need to have that person-centered approach. Who was Helen? What did she like to do? What was she involved in? Is there some way we can lead her back into doing that? Well, I was an advocate for my region, so I suppose it didn't take too long for me to, when I finally found the strength to start shouting about human rights, to say that somebody found me to say, God, will you speak publicly about it? And 13 years ago, I was the first person in Ireland to ever go on public television and say that they had Alzheimer's. You know, which is absolutely incredible to think that they brought people from other countries. I watched all these great advocates for other countries. So needless to say, I haven't shut up since. So I think that if we can manage our care, if we can manage and come up with good quality of life, person-centered, flexible, you talk about flexible care, support for us, but we need the support if we need it. So for example, when I had the stroke, if I needed support for 24/7, then I needed support for 24/7. There was no other need to put me into a care home for that. And I need consistent care and people that you can trust, and you know, time for conversations, and just not always about tasks, you know, just have somebody come in and just trying to talk. And then you talked about training. Well, training has changed, and that's a continuum now of training for people with dementia. So we need that, and I talked to you about all the necessity of having technology. And then, of course, I always have a message for the professional and the policymakers. Well, some of them are here, PhD students, some of the policymakers. So we'll just remind them a little bit that we're more than diagnosis. I'm constantly telling people, living alone is a reality, and it's not a failure. It's a reality that we live alone. And there's tremendous service providers that can help us live there, and support at home. But it's a must. It's a right. It's not a privilege. And home is where we want to be remembered by. And reimagining home care starts with by asking us, you know, the people who live at home every day, what it's like. So I'm just giving you a brief snapshot while I'm watching Fiona out of the corner of my eye to see if my time is nearly up. So, but to recognize, the call to action is about recognizing our human right, about funding flexible personal care, and to train the carers and have an emotional connection. You know, we need to have that as well with our carers. And to involve people with dementia in designing services, no matter where you are. You know, all too often we get the piece of research somebody has done, they're 3/4 way through the research, and then they say, oh, Helen, you know, could I borrow your name? I need to apply for $1 million, you know, in research. And I'm thinking, but hang on a second, I wasn't there in the beginning, so I really don't know where you are. So in the beginning, I did that. I did a lot of it, but I become very smart now and saying, well, you know, I don't need you to bring me to the table. I need to be the voice at the table. And so that will help me through. So I think that involving people with dementia in design, you know, prioritizing our quality of life with dignity and safety. And I know that, you know, all of you, when you go home to your countries, that's what you'll look for: dignity, safety for people. But you will also remember that all people like us are people with dementia or without dementia as we age. We just want hope to live out our years as the best we can. So with Lexi by my side and a cup of tea in my hand, and maybe in the evening a glass of wine, and the tools that I trust, this is still my life. And it's the one that I want to live fully and I want to enjoy. I want to enjoy every moment. Every moment is nice in my house. There are many dark days, there's loads of tears, there's loads of frustration when I cannot remember what happened yesterday. But you know what? That's okay. Thank you for listening to me, and I hope Brendan. I did forget one thing to say to you, Brendan, that I would be well recognized in this country for looking for value-based healthcare, because I always want to know where my money that has been taxed on every month is going. So I want to make sure that there's value for money. And I think, you know, at the RSI, that you know, that's where you influence change, and that's where you should make changes, because we do want value for our money.
Thanks very much, Helen.
Oh, I'll go and sit that, Brendan. Oh, yeah. Oh.
Thanks
I
so
know
much. Thank you so much, Helen, for your insights and for sharing what it's like to be you every day, which has always been invaluable. And Helen has been a valued colleague for over a decade now, and has given us so many insights that have shaped the work I know certainly in the Research Institute here. Lots of food for thought there. So I'm happy to throw this open now for questions or comments, and will we be getting stuff online as well? Okay.
Maybe just encourage them.
Yeah. Yeah. If anybody online wants to put a question in to the chat, yeah, great. We'll see that.
I'm Karma Gagan, and Brendan, fantastic presentation. And I just want to tell you that nothing really has changed since I became a carer from my late mom in 2010, and it's absolutely horrendous out there. And I am advocating for the right to stay in the home and a statutory right. I don't agree with, and I think it's common knowledge, I don't agree with the way the home care package is provided by for-profit companies. I have big issues with that. And I suppose we have to go back to community. And I was involved in Forum Connemara Leader Company, and there's more than one in every county probably. And we, through my canvassing on the board, we piloted the home care package, and now they have set up Connemara Care. So the carers are in the community working. They are paid above average wage. Their training is paid for, their mileage if they have to. So they have common ground with the community, they know who they're visiting and everybody. And there is continuity in the carer coming to the home, which is really important. And they were issues that we had when I did get bits of home care package, which was a constant battle. It was someone different every day, which was upsetting for my mom first and for me totally. And you're letting somebody into your home. So there are, and I really think that it's not money. We don't need any more money, but we need management of what's there. And it maybe if as we saw from your graphs, it's just incredible. It's completely a postcode lottery. And I would say again, I know there's a lot of work being done about primary care, and I think that's where it's going to be a game changer when that's really established, and that the whole picture is looked at. It's not just personal care does my head in. If I hear about a shower again, and I would go into orbit because they leave after drowning my mother, and there's pandemonium because they dragged her out of bed at 8 o'clock in the morning, and I have to spend the day. I mean, and then the other thing you said there, which is so true, the carer is burnt out, which is what happened to me. And I've actually been ill more or less since, and I hadn't thought about it. It's constant. And of course, that's how I started advocating. I'd met Helen, and I thought, yeah, this is one way. Somebody has to tell what's actually happening there. So I could write many books. Thank you. And of course, Helen's an inspiration, and that's what keeps me going.
Thanks, Carmel. I don't know, is there any, do you want to come back on any of the points there, Brendan?
Yeah, just on your last point in terms of that care cycle, it's becoming increasingly evident that it's a much bigger issue than we realise, and it's going to be very difficult to stop it, because once something gets, snowball gets rolling down the hill, it is hard to stop it. And I think your point at the beginning in terms of provision across the kind of the public versus private, I'm always a little bit agnostic about this, because if the private sector weren't there, we would have had to have a completely different model, which we just weren't capable of doing. But we need a lot more carers, and that Connemara style model, I think, will work effectively across the country, but especially in rural areas. We know the most difficult places to access care in the private sector is in the rural areas. And I was at an event last year, I think it was Sage Advocacy, and they talked about GAA of care. So that whole element of using the community and the resources which are there, the personal connections, to allow for care to be provided to those who need it. Maybe not nationwide, but in those pockets where they really need it more. I think there's clear pilots like your pilot you mentioned there that could be used and expanded across the country.
Thanks, Brendan. Any other questions? This one here.
Hi, how are you? My name is Anne Roddy. I actually work for Sage Advocacy, so thank you for the shout out. I'm really interested in the money follows the person kind of concept. So I've been working in the Midwest up until recently, and I'm recently moving back to Galway in terms of work. But a lot of the clients I would see are people who were managing sort of kind of at home, ended up in hospital with a fall, discharged from hospital into step down, which is typically in a nursing home facility on transitional funding. The point the other lady was speaking about in terms of carer burnout, the carer, maybe there was a carer at home, can no longer take them back home, it's just too difficult. But it's very easy for me, I am an expert at fair deal forms now, I know them inside out. It's very easy for me to get that person long-term care, but my job is to do what that person wants. And in many, many cases, that person, even with a diagnosis, dementia or otherwise, they want to go back home, but they need the support to do that. We can get them the money to get into nursing home, but I cannot get them carers in places like West Clare and stuff like that, impossible. And there is nothing the family can do, like short of, they're willing to pay a certain amount privately, but I really think that's really, really important to kind of, whatever it is, 1,200 a week for a nursing home in Ireland, what that would buy you in terms of carers 24/7 is phenomenal. So I'm just wondering, is that part of the discussion about statutory home care, expanding that at all?
Thanks for that. As far as I know, it is not, okay? And it's very interesting that, you know, if we're ill and we can be transferred to that step-down facility, that money is paid at step-down facility instead of to your family, or instead of getting that care at home. And you might be in that step-down facility, as we see, for far too long. I mean, we could be there for 2 or 3 months, and next thing, the next place is you're sent to a nursing home. Not a home to where you can get services provided for you. So it's not, as far as I'm concerned, it is very rarely ever mentioned anything about statutory home care, about step-down facility and then getting home. Where instead of people, I've known people that actually, I've been in a hospital and visiting somebody, and I heard a family member saying to the patient, "You are not to leave here until they give you," and this is actually live happening, I'm aware of it, until they give you the package, the appropriate package to go home. I'm not going to step-down facility.
No.
I'm not going to a care home. You provide the care that I need at home. There's plenty of services out there.
I think, just to come back on that point, it's all the way back through, because a large part of my work is working on delayed discharges from hospital. So exactly to your point, Helen, people are not discharging from hospital, from the acute setting, because they know, you know, and a lot of people are very, very fearful that once I'm sent to a nursing home, I'm never getting out of it. So it's a complete cycle. So I'd love if we had the data and you could run those ESRI numbers on a Brendan. Yeah, thank you.
Yes, Brendan.
Yeah, no, I think, and you made some very good points, and building upon what Helen spoke to earlier, people have dynamic lives. So she mentioned having a stroke, and you get better from the stroke. But the decision that's made right after a main event like that happens is very, very important. So it was actually yesterday I was doing a piece of work where a reference from Norway showed that for individuals who had a hip fracture, some went to institutional facilities for step-down care, some went home. Those who went to institutional facilities were 50% more likely to end up in a nursing home 12 months' time. That institutionalization default, which we have here, which is largely caused by the statutory the statutory fair deal scheme, and no equivalent statutory home support scheme, is embedded in the system. And you mentioned you're a whiz at doing the fair deal. If there was a statutory fair deal or a home fair deal for home support, you'd be a whiz at that as well, and so many others would. And that post-acute discharge would increasingly move more towards rehab provided in the community and at home. And you'd remove that institutional default, which is currently in the system. Yeah. And that's why putting them on parity, putting them on the statutory footing across both home, residential care, I think is essential. Yeah.
Thanks, Brendan. Any questions? Anybody online? Any questions or comments? Okay.
Hello, thank you very much for your both of you presentation. I have one question for each person. Is okay?
Yeah, that's okay.
Okay, yeah, thanks. So for Brendan Walsh, and actually I'm a PhD student here, and my project is also about home care for rural people. So I'm quite interested in that you just mentioned the population-based resource allocation, and then in your like amazing presentation, like you already mentioned, there is a variation across the 6 regional health areas, and then in the model of population-based resource allocation model, I think they consider rurality as a factor, and then but based on the complexity of rural places, I'm quite interested, and what do you think of this complexity of rural places, and then how to consider this rurality in the home care resource allocation? If you could explain a bit more about this.
No, thanks very much. And I think I spoke to Kieran a little bit about your research earlier too. It sounds very interesting. So just in Ireland at the moment, in terms of how we divvy up our healthcare budget, we don't divvy it up in a very systematic way. So this population-based resource allocation essentially means we will be apportioning the funding to each region to do what they want with it, but to each region equally, taking into account the size of the population, the age and kind of sex structure of the population, the deprivation differences across population, and then rurality. And rurality becomes very important for services like home support. So in Scotland, England always gets a lot of attention when it comes to having a very good healthcare system. I actually think Scotland has some of the better NHS type systems out there, especially for older people, but they have a very specific weighting on rurality for, say, home-based care, which takes into account how difficult it is to traverse across Connemara, for example, for one carer compared to traversing across, South Dublin on a bicycle, for instance, you know what I mean? So that rurality aspect, it may not matter too much for hospital care and so forth, but it's very, very important for ensuring there's requisite resources for things like home support. And what my understanding is, the government or the Department of Health at the moment is trying to establish that population resource allocation so that in a few years' time, the funding will be apportioned effectively and efficiently based upon the kind of formulas which take into account the variations we have across region. But until that, the slide that I'm after showing you there, that's going to exist because there's no systematic way for us to stop that inequality emerging.
Very much.
Did you have a question for Helen as well?
Yeah. Helen, thank you very much for your stories. Yeah, I'm quite enjoying that you were saying the hope. And then I think it's very important for everyone, not only for dementia people, but also like for everybody. Yeah, I really feel impressed by that. But I have a question about you said like your daily life is food is around with the technological system. And I was wondering like, is it only you or like many people, they are eligible for these technology systems, or how did you get those daily technology system around your daily life? And then is there any standards for that? And then how long it takes for you to get used to it, or it doesn't have any, like you just feel it's very useful at the very beginning, or do you have some stressful time to try to get used to all of these technologies?
Excellent question, actually. I'll take the first part, but the first part about, about funding. And this is where when we talk about statutory right to live at home, we want technology to be part of the package that we are going to get to stay in our own home. Okay, because if we have a package that we have technology that's going to help us to live a better life, we're going to prevent the state from paying a lot of money for us, where we'll end up in hospital or we'll end up wherever. So if I fall, for example, my watch asks me, am I, have I had a bad fall? Okay. So it's a common occurrence when you have Alzheimer's, by the way, that you fall. So I think that we want that to be part of the package. And broadband, we don't, we have terrible Wi-Fi in areas of this country, and we want to make sure that Wi-Fi is there. We don't have to maybe have all of the technology, but the more we can have, and in trying out Alexa for the state, this was the Department of Health that asked me to try it. Well, that told them that if we have the right connections, if we have good Wi-Fi, well then older people will not be isolated, because they'll be able to talk to Alexa, to hear their piece of music, or to listen to the news, or to whatever. Alexa, and I use Alexa, I know there's many others, I can't remember any of the names, but we need it to be part of the package. So it must be part of the package of living at home, that if the basics of technology are there for us, because safety is important. So if we fall, somebody needs to know, so we maybe have a chain around our neck, so we have a bracelet or something that we can press. And they're not massively expensive, but they're massively expensive on the state, on the Department of Health, if we don't have them. So I think that's really good. And the second question you asked me was around,
are you getting, like, how long, like, are you getting used to
oh, getting used to it, yes, sorry. Oh, well, now that, have you all evening? That's another difficulty. It took me a while to get used to it, of course. And as I said earlier when I spoke, the biggest difficulty I have when all of my IT goes down, then how do I reset it, and passwords and all kinds of things. So, it is more difficult. But of course, I have to write everything down. So it's supposed to be written down, and I'm supposed to be following all of the instructions. But I don't get it right, and it is a bit frustrating. But you see, if you live alone and you have a package like I have, having from the Alzheimer's Society, having somebody come to my house to do brain exercises with me and to help me to stay focused, you know, on all the chores in my house. So I have guests, so then the beds need to be made the next day, everything needs to be done, you know, so you're supported to do all those things. So it's again, if all this technology goes off, it's just part of the job that she helps me to reconnect again with the world that I live in. And that's important. But, you know, I think when you have a memory issue, it is a different type of care, you know, than for all older people. You know, some have memory issues, but when you have a memory issue like I have Alzheimer's, well, then you do need somebody to support you.
Yeah.
But I'm lucky, I have a grandnephew that is always looking for €10.
Built-in IT support. Thanks for that. I'll just take a final question from Maria.
Thanks very much, Brendan, for your presentation, and Helen for your contribution as well, really insightful. I suppose I just have a question. You may not know the answer to this, but it's about the kind of funding model for home care at the moment. Public home care is free at the point of use. And there's a lot of talk about having a fair deal for home care. So does that mean that the department is considering user charges or co-payments for home support? What will that mean for the actual implementation of it because of the kind of assessment of needs? And is that perhaps one of the stumbling blocks to us getting a kind of statutory home care scheme, trying to figure out what this funding model is going to be? It's just, I don't know if you have an answer, but maybe any thoughts on that?
Yeah, I don't have the exact answer, but if we were to try and impose a fair deal for home support, there would be co-payments. When it comes to co-payments for home support, though, why they're there is important. So, for example, are we including co-payments to reduce the amount of money that the state is going to pay for this? Okay, if we are, then that can be thought out and potentially acceptable. Are we including co-payments to try and reduce the demand for home support service from individuals? We all know in terms of healthcare systems rationing support, we put in co-payments or we put in waiting lists. We have a waiting list at the moment for home support. And because there's very little evidence showing that for social care type services or the care that kind of Helen has spoken to, that co-payments would actually reduce any demand, or if it did, it would reduce it very little. And I would suggest we already, to some extent, have co-payments in place, because like we have figures where potentially a fifth of all home support hours provided in Ireland now are purchased privately. And a key reason why they're purchased privately is because people cannot access public supports. So we've almost quasi have developed a co-payment type system already within this country. But I think the importance of developing a statutory support system is kind of going back to the points I made to Anne earlier. It's that it's placing home support on the same footing as institutional care, and that home first becomes the default thing. And there's good evidence, Sharon and others have done work in the past on this, showing that people who want care are happy to pay if needs be. But I think why they're paying is something that should be, thought out. And if, for instance, one of the reasons we want to, from a cost-effective point of view, if we want to use home support to reduce the use of residential care, so 8 hours of home support a week is about €250. One bed in a nursing home in a week is €1,200. So if we want to potentially reduce costs by moving people from nursing homes into home support, do we actually want to include barriers that will potentially lead to higher costs for the state because we won't have many people using the home support as we should? So they're the kind of the issues I think people are grappling with at the moment. My personal view is I have not seen any evidence to suggest that co-payments for a statutory home support scheme would do much, except for potentially increase the amount of funding or reduce the amount of funding the state pays for home support on one degree. But if that means that more people don't use the service and end up in residential care, probably not going to be saving any money at all. Yeah. I don't know if you've got any 2 points on that.
Just for Sharon as well, doing that research. I remember we did research for people with dementia. Would you contribute? Would you contribute to your own? Of course we'll all contribute. you know, where we can, you know, just, you know, based on a person's income, you know, so there's nothing that ever says that we want everything for free, but, you know, we need to have that support.
Okay, I'm conscious we'll have a coffee break, and everybody's here if you want to speak to them during the break. I'm conscious that issues around technology were really to the fore in what Helen was talking about, and it might be interesting to see, you know, how if we factor more technology into those figures that Brendan was presenting, how that might change the landscape of care in the future. But the session after the coffee break, Professor Martin Orrell is actually talking about technology, so I think that's going to be very useful and very interesting. I want to thank our speakers, Brendan and Helen, very much for a really, I think, thought-provoking session, and has really set us up well for the rest of the afternoon and for tomorrow. And thanks very much for your participation.
There's tea and coffee out in the there's tea and coffee in the multi-purpose, just in the entrance here if you want to come down this way and out. Yeah.